Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator, and this is session number 158. We have a very interesting, truly complex coronary intervention today. A patient with the previous TAVR with the Edwards device and having in-stent restenosis. We'll probably using a multi-modality approach with the imaging guidance. With this introduction, let me take you to the cardiovascular laboratory where Dr. Kinney and Dr. Sharma are standing by. Samin, Anu, good morning.
Side hole, yeah. Good morning.
Good morning.
Side hole. The damping, yeah. Okay, so
Post
let's.
it if you need it.
Good morning to all our viewers, and ready to start. Few minutes late. Sorry for that. Usually up to date time. If we can go to our slide presentation, so we get into this case. These are our supporters. We are thankful to them, and disclosures are not changed. So this is, I said, case number 158. 80-year-old patient who had AS and CAD. Presented, had a TAVR earlier this year in March, and then he presented, he had a PCI in the past and presented with non-STEMI. In July, that time had a left main and 3 vessel disease. Risk factors on left side, including heart failure, but preserved ejection fraction and CVA with no residual deficit. So basically, patient has a SAPIEN 3 Ultra TAVR in March, and the time CAD was not significant. We left it alone, and we know that the whole question of CAD and AS is coming to the limelight with a complete TAVR trial ongoing to answer this question that do you really need the management or CAD management in these patients. So this patient then presented with non-STEMI last month at outside hospital and then was transferred and had a distal left main bifurcation, which will show along with the progression of the RCA stent which was placed last year, and we'll show you all that. And then that time patient did have a left main PCI. LED was good, so we put a stent across with a kissing balloon, did very good, and that time syntax score was 34, and then now has a residual syntax score of 7 for the right coronary. So let me show you that what was the right coronary was. This was last year in August. As you can see, multiple lesions in the ostial and mid to distal RCA. That time patient had a rota plus stent. Look at the very nicely placed and expanded stent at that time. Now, whether this happened something, and you see now patient on the not only the stenosis, there is a ISR of the proximal part and ostial, but it looks like there is a extrinsic pressure, compression of the stent. Whether it's underexpanded or not by the angiogram, if you see angiogram in the center last year, what we left, and we post-dilated with a 4O very high pressure, very nicely expanded. You see this is the pre-TAVR last year, and then now the stent underexpanded, as well as re-stenosed. And what exact mechanism, we are going to look into this aspect, and this is where our case is for today in terms of what to do, that imaging guided PCI of this calcified RCA, underexpanded DES ISR using device synergy. Question is, we got few emails already that ELCA, rotational atherectomy, IVL, or re-stenting. So this is basically the issue will be, and we are ready. Anu, you want to show your things first?
Yeah, so if I can show you.
So this is the left system first?
Yeah.
You see
the engagement, but same, I think we are behind the valve, not through the valve, behind the valve, and able to get circ is okay. Then we have non-obstructive LED.
Yeah. So there was one stent from left main to circ. There is already a stent in the LED. We just did a kissing balloon, and patient has done very well since then. And now here for this, you can see the mid to distal RCA is good. It's only proximal. Can you just do a cine, dry cine there, so everybody can see a little better the unexpanded stent now? Yes. And this is one very nicely expanded. Yeah, see this now. And you see there is a dampening of the pressure. This should show the pressure on the lower.
Side by side.
Side by side pressure, please. and it's a 7 French guide. So clearly there is no side holes. I always suggest the side holes.
No. If I want to do OCT, that's the
Yeah,
reason
because
we
of
start outside
OCT,
holes.
we really wanted to understand the mechanism, and hopefully we'll try to answer this question to our audience. When do you use a rota, IVL or laser in this under-expanded stent? We are not talking about ISR only. We are talking about the under-expanded stent. That's exactly this patient is. ISR is part of the under-expanded stent, we all know, and that will be the part of our discussion also. But more important is that how to differentiate, one, the mechanism, and how do you alter your strategy based on your imaging finding, not just by the angiogram, but a little more than that. Yes.
So, Samin, let's say there is a cath lab which has limited options of imaging. Could one even make a case of putting in a high pressure balloon and restenting?
Yeah, so this is the kind of case, I would say that probably high pressure may not completely work because it looks like a lot of calcium.
Right.
So probably you'll need some ablative technology. Now, is it a must? Probably not. You're right. You can just go with a very high pressure and then see. That is one way. But idea would be that what happens usually in these cases, your balloon slips and watermelon seed effect of the balloon, and it may cause even additional injury into the various other aspects of the vessels. So I would say the IVL, the high pressure alone will not be preferred, in my opinion.
Okay,
So,
good.
can you show the OCT as good?
Yeah,
I'm going now.
I am keenly looking forward to what we find with
Yeah, we got image.
imaging.
Great.
Disengage the guy.
But
So I'm checking.
Okay.
Start of the pull box, then it is expanded. Go to the proximal. Yeah, I see the under-expanded stent. So I show you the exact G point. This is in the guide catheter. Go to this. So yeah, this is just the ostial RCA stent, like concentric neo-intima.
Everything is good.
The
Go to
stent
sleep.
size is
Give me
follow,
20 minutes.
but
Yeah.
it's expanded just like
Beautiful.
2.3
Yep.
or something.
Beautiful. Yep.
Do you see calcium
We'll give some
outside?
medicine,
Huh?
So actually, I don't see too much calcium.
Yeah, it just
But looks
stent
like
compressed.
it's in the stent, like attenuation. Looks like it's a neoatherosclerosis with lipid, and actually not much calcium. Yeah, the proximal part is well expanded and like no stenosis, but just the ostial
Tower afterwards.
here.
Huh?
Tower after
Stent
stenting.
is under expanded and looks
stent
like
was last
not
year.
much
Tower this year,
calcium.
March.
So maybe compressed by the tower balloon.
Yeah. So other question was whether the stent was compressed at the
By the
time
tower,
of
yeah.
the balloon expandable tower, right? That is one of the mechanism because we saw it.
think that
It was very nicely expanded, as Anu just pointed out. Guy to like disengage. Yeah.
okay.
Yeah.
Nothing
So
will happen.
just pointed out that if was it maybe it was compressed. Yeah. See the
By the tower
tremendous
valve.
the pressure dampening. So whether the stent was compressed and that is what causing it, is it not a calcium or but it's the intimal hyperplasia, correct?
Yeah, a lot of
Me, that's
neointimal
the
hyperplasia, also mechanical problem. The stent is under expanded, but hard to see the like a lot of calcium. I see a little bit, but also a lot of lipid plaque, and like large burden of the fibrous plaque.
Lipid inside?
Inside also because there is a like
Neoatherosclerosis now.
Yeah, attenuation. It's a lipid inside.
Right.
So then what you want to do? Just ablation?
No, but I think in this particular case, then we can avoid the rotablation, right? Because there's no calcium. So what I think we go with the strategy with the laser, and we can use a 1.4 millimeter fiber. We have 7 French guide.
so
laser will
Samin,
still be helpful. Yeah.
I'm going to lean on my expertise with the laser again. Haven't done a laser case in 20 years, but why a 1.4 and why not a larger one?
So 0.9, 1.4. So other one we don't even have a setup for here because that is more for remember EP the 1.8 or 1.9. I don't know what size that is.
So
but clearly 0.9. Usually what we use for corner is 0.9, and then we can go to 1.4. Yeah.
Compressed
So
by the
the
balloon.
Yeah.
1 point, these
Nice
sizes
picture.
have recently changed. Before
Yeah.
it used to be even a 2.0 and even a It used to be Spectranetics, which had made even a 2.2 and a 2.4 in 1987 or 88, I remember. And of course, that was removed. But the intent was that for ostial lesions, all you needed to do was be coaxial and.
What are we doing?
IVL.
For what?
I'm sorry, say it again now. What the strategy is based on this, yeah.
If it's intimal hyperplasia, why you think?
And under-expanded stent. Right?
No,
Stent is compressed or no?
Yeah,
What?
compressed,
I can
compressed.
tell you, it was compressed by the tower balloon.
I think one of the reasons is like hinge motion
high
of the
pressure
ostial
balloon should be
RCA,
okay.
maybe mechanical
Let's try
stress
the
by the
laser.
hinge motion.
Then don't do no IVL. Yeah.
Yeah. Okay. So question comes is, based on what we learn now, that do we need to do IVL or not? So I think whatever discussion is, we can have very clear cut. No, but move him out, help him out, please. The guy is going to contaminate everything. Move the camera.
Look, all I can tell you is doing imaging here was the most critical.
Right.
Gives you a much clearer idea, probably less of a role for IVL or rotational ablation, and probably a very good case for the laser.
Laser plus high pressure, as you said.
Right.
Now
right.
even
IVL has no role at this time. Here.
IVL definitely does not have a role because there is no calcium. One.
I don't know about laser. We could have just tried a high pressure balloon.
And the second issue remains is that clearly that if would have been a calcium within the stent or behind the stent starts. And remember, the people wanted to ask our strategy after the OCT, how would I change the program? Yeah. This 1.5 or no? 1.4, right? So what is the third catheter? Anybody knows the peripheral is 2 or what? What is I know that we have 1.9 and 1.4, and they go to the 40, 40, 60, 60, 80, 80, but 1.4 goes only to 40, 60 fluence, and there is a third catheter which is peripheral. Anybody remember the size of the catheter? 2 or what? Anyone knows? Looks like the peripheral team is not here, and nor we have used ever.
I think it's a 1.9 and a 2.0. Yeah.
Okay, so those are peripheral. So 0.9 and 1.4 are coronary. So 1.4 will go through the 7 French, and 0.9 will go through the 6 French.
And they're all monorail.
All monorail, yes. So we go with and then also question comes when within the stent that do you want to do with the saline or the dye? So key is the whole concept of the laser and the calcific lesions and undilatable lesions is by the explosion of those vapor, the bubbles, and those explode if you do with the dye. So in the native vessel has more chance of dissection and perforation, but within the stent it's a 45, 25. Okay, 45, 25 is fine. Yeah. And so this one we'll do saline or what do you want to do?
Always with saline, no?
Saline, yeah. So except in the under-expanded stent, that do you go with the dye? That's the only thing. But yes, always with the saline. But in the stent, you are not less worried about the issue of perforation or dissection. Yeah. So we are going to start now. And once you say I'm going to start flushing.
Why it's not working, my friend?
Guys, it's not working.
Hello? It does not show any light though. Go 60-60.
No, quick ready. Yeah, go for it.
Okay, 60-60.
No, the 1.5 goes to 40 only, I think. 60-40.
60-60.
Yeah,
40,
remember?
good?
Yeah,
Okay.
1.5 goes to 60-40.
The real important thing to notice is the laser catheter has to be coaxial always.
Right now we are doing it with the saline. Your balloon ready? 3.5.
Have the OCT ready?
Or do you want 4.0? What is the vessel size?
Like 4.0. The stent is 4.0.
Then get a 4.0 balloon, right?
Can you do it again?
4.0, like 4.3
Saying ready?
or
Press ready?
something.
Press the ready again. Once somebody at the machine, please. Is ready? You see? So just want to tell our viewers again that while 0.9 fiber, you can go to 40, 60, 80 and influence as well as energy. With the 1.5, you go only 60, 40 maximum. Yeah. You want to do a little bit with the dye?
One of the common practices I used to have was to, as the laser is advanced, slightly pull back on the wire. Slightly.
Just flush a little bit. That's it.
I'm giving a little dye now.
Okay, it crossed.
You want to come out a little bit or you're done? It's the most of the ostial lesion, right?
Right.
Yeah, also just also like very short.
I guess we did it.
Huh? Good.
Okay, let's do the OCT again.
Sure.
Right? We did few runs.
Yeah.
You want to dilate with a balloon again or just by itself
I
now?
want to do the OCT now.
Okay, we are doing the OCT again.
Sure.
That would be the most optimal way to see how much difference have we made.
Yeah. Yep.
I don't think we'll see any difference.
Yeah.
Yeah.
We'll see a difference only when we do a high pressure balloon.
Right.
Yeah. So question basically was that all the change in the strategy happened after the imaging showing that there's no calcium, there's some intimal hyperplasia, and there's unexpanded stent.
Yeah, true.
Those are the findings here, right?
Yeah, true.
Kiski?
Yeah.
Anything else on there?
So behind the underexpanded stent, a lot of like fibrous plaque looks like not calcium, but a lot of plaque burden behind the stent.
Okay, so they're also saying that there is a plaque burden behind the stent struts. And remember the earlier data have shown anytime plaque we left behind the stent struts correlate with subsequent restenosis. So therefore this patient did have a plaque at that time. When we did last year rotablation plus stent, that may have contributed, but more importantly, contribution occurred because the stent got deformed at the time of balloon expandable, the sapien deployment.
Okay, Kiski, we are okay?
Yeah, it's a good place. Can you check
How
the
much,
path?
Anu, how much was the reference vessel diameter with
Four.
the
Actually, the 4.5 and a stent is 4.0.
It's a 4.5. He's saying 4.5.
4.5? Okay.
Yeah, good clearance.
No, let me go in a little bit, okay? Okay.
Yeah, great.
Samin, so let us assume
closer.
that there is a modest amount of plaque underneath the stent.
Good, right?
Yeah, good.
Would
Yeah,
it be an absolute contraindication to even consider IVL in the absence of calcification? But knowing the fact that there is a residual
Great image.
significant plaque?
Yeah, so very good point. I think that's an excellent point. That, huh?
Can you do full screen OCT?
So I show you this is after the ELCA. Yeah, I see some like intimal disruption after ELCA, like irregular surface.
Mm-hmm.
Yeah. Yeah, still stent is occurs and expanded, but it looks like not much calcium again.
So coming back to the point, Samir, that if there is just a plaque and it's not a calcium,
What size
Yeah.
balloon you have?
4.0. We're going with a 4.0. 4.0
I
balloon.
think 4.5.
Huh?
4.5.
No, but let's do 4.0 first and then stent we can put 4.5. Isn't that there's a 4.5 Zions nowadays?
No, there's a Megatron also. Oh,
No, but not Megatron. No, I'm saying 4.5 Zions, what we have? 12, 16, see?
Megatron. 6.
No, not Megatron now. No synergy. Yeah.
Nothing to do with that.
So we put a Zions other side, the left main. Yeah, and I know. So what 4.5 we have? 15. Let's get a 15. Yeah, keep it, but we'll see. Yes. Okay. So now we want to comment on what you found on the OCT.
No, you
To the
saw
people.
some disruption of the intimal hyperplasia. Go back there, show it.
Yeah, disruption
Yeah.
on the like neointima.
But the question, could this have been done by rota also?
Yeah, but still stent is underexpanded, so maybe we need a
Cutting
high pressure
balloon?
Yeah, I was
Yes.
thinking of the cutting balloon,
got-
of course.
Yeah. It looks like if we had done just a cutting balloon, could have done that. Okay, down.
Yeah. See, remember I said this going to watermelon seed effect
That
is
is-
very common with this,
Guide was too deep.
and we'll go slow. And one of the way to is that you have half inflated balloon and go slowly.
Okay, down.
Yep.
So, Samin, when was the last time you used the angiosculpt?
Go.
Oh, angiosculpt
Years.
actually we do use, but now we are using more score flax.
Right.
But the mechanism about the same with both of them. But both are good technique. I would say if need to be, we'll go with the slow inflation. And now we are going with the 4020. It's good. 24. Nicely
So now
expanded.
we see a full expansion.
Yeah.
Yeah, 24.
Get us a 4-5-15 stent.
Yeah.
So next we'll do the OCT after we stent Kiski, right?
Sure.
You don't need another OCT now.
So coming back to the point that if there is just the plaque, so I think the plaque alone with a non-calcific, I would say that IVL or even rota will have a very limited role,
So now
because
there's
that
no
can be
damping.
compressed. And now see this now, no longer dampening.
Yeah. Okay.
We are the hemodynamics.
Put the picture in picture. Hemo.
Show the
on
hemo.
side.
Yep. Yeah.
Okay.
Look at that.
Excellent.
Yep.
Yeah, clearly.
See there. Good.
Wow.
Okay. Let's get the stent. 4.515 Zions. What is the name of this? New different name or same?
Okay.
Show me the box.
Put the hemo by the side of the angio.
Yeah. So it's the same Zions Sky Point 4.515. So like compared to Synergy, for ostial and large vessels is Megatron, the name is here just the Zions. Zions Sky Point 4.515. And this is the case who has multiple lesions. PCI we have been taking care for a long time. And of course, this now, with the progression, so it's very unusual that a patient has so much progression of the disease after the stent deployment. I understand this RCA got deformed after the balloon expanded because the stent was sticking out, which is okay. But in this particular case, the left main progressed. He developed the non-STEMI, knowing that 5 months ago, you want to take a picture? 5 months ago, the ostium, left main was only 30-50% at the time of the TAVR. And that is what we do nowadays. That angiogram at the level, at the time of the TAVR.
And to go
Okay.
right?
You have to come back 1 millimeter, good.
No, I think I will pull back. Guide.
Good, right?
Yeah. Okay, go.
Okay, going up now. Since we are within the stent, we can go 20 atmosphere. It's a 4.5. And then just do a little flaring of the ostium. Ostial flash balloon we have not used in a long time. We don't even know whether we carry it now. Used to be a good device, but I think it just went out of favor. And you want to comment on ostial flash? Why don't we use it now? We used to use it in the ostial lesions in the past.
You have to have few millimeter more.
No, this is
sticking out.
sticking nicely. Yeah.
But there are two layers now.
No, this is one
will
layer.
not work.
Now 2 layer, yeah.
No, 2 layers, yeah.
Angiographically is absolutely pristine.
Huh? Oh, no.
Come.
So this 4.5 at 20 atmosphere is almost 4.7.
Yeah, but again, the question is if I need to post dilate, we go with a 4.5. Do you want to post dilate now or do you want to do it on all the looks?
Post.
Post first, yeah.
Post it and then do the OCT.
Yeah. No, do the 4.5 balloon, please. 12 millimeter 4.5 balloon.
One of the live case long time ago, we did show the ostial flash.
Yeah. No, we showed the ostial flash 2 times. We have shown. Yeah. We have shown 2 times we have shown the ostial flash. So now the point here, not using ostial flash will be that there is a double layer of a stent, whether ostial
Double
flash will
layer
work.
and, we have used in few cases.
And we had 3.5 and 5.0. We looked into it because I personally haven't used it in the last couple of years now.
So, I mean, the segment of the vessel after the
OCT is
newly
ready, right?
implanted stent, do you think that needs to be expanded also?
Yeah, we'll do this one now. Yeah. Yeah, let's do this first. You want to go a little distal at the edge?
No,
I mean,
copy.
overlap. Yeah, we'll do the overlap. Definitely. Okay, here. 20 atmosphere.
Yeah. Okay, down. Who prepped it full of bubble?
1 second. Okay, let's do it again. Right?
Go up here,
Yeah.
in between.
Yeah. This is the overlap area.
Okay, have the OCT ready, and I think, oh, bigger bubble, bigger bubble.
Make sure this tight. Cannot have a loose. That's why the air keep coming. Good. And we do the ostium now.
Go up here.
.20 atmosphere.
Good, down.
You can remove the pacemaker.
Okay, let's do the OCT.
Sure.
Just to extend our academic discussion, would there also be a role of a drug-coated balloon here?
Yeah, so I mean, I would say the drug-coated balloon will be useful here only if you're not putting another stent.
Right.
But I think we have done a lot of disruption with the laser and so. But I would say that yes, the drug-coated balloon in a large vessel, I mean, a small vessel is more. But I'll just show the data for ISR paper. That first episode of DES ISR, the treatment is re-DES, and that has been better than drug-coated balloon. Now, once you get a recurrent or a small vessel, maybe that's where your drug-coated balloon may come in. So vessel less than 2.5, or you have more than one layer of stent, then drug-coated balloon will have better outcome, long-term results compared to the re-DES, yes.
In addition to the modality, does even a clinical subset such as presence of diabetes make any difference?
All
for
those
any of
factors,
these?
diabetes, kidney disease, all are very, the risk
Not good
subsequent
clearance.
restenosis, besides the mean MLA,
Maybe guys should be a
calcifications
little
and
more
so.
inside. Yeah, now it's great.
Okay, ready?
Yeah, ready. Yeah, great image.
Such a
Wow.
wonderful expansion
Take everything
there.
out.
Yeah.
You have
He lost the
almost
vision.
a 5-0.
Yeah, perfect. Yeah,
No,
well
no
expanded.
question,
You can
no
take the wire
question of any under expansion there now.
No.
We'll
Excellent.
take a last picture with a little nitro. Let's
Keski, if you can comment
read
on
this first.
what
Yeah, left
difference
one touch.
did it all make with the area of the plaque under the
actually-
stent which you.
Actually, the tightest area is like 1.7 or something. And now I show you the post area is
Ready?
like
Yep.
12. Like unbelievable. And yeah, really expanded. Little
Super
bit,
expanded, my
yeah,
friend.
super expanded.
Super.
Let's discuss the
Little bit like
OCT a
plaque
little more.
Yeah, we can show
occlusion,
it.
maybe some
Test
kind
them
of thrombus.
exactly what it was and now.
Yeah, but it's perfect.
So go back to the original, first one.
Yeah, that patient has
So
been
we show
assigned
that
to
intimal
Marty Goldman, right?
hyperplasia, right?
Yeah. And a neoarteriosclerosis.
Yeah, yeah. So here,
Who's in room
This
6?
is the, yeah, here is the
okay,
lesion.
just stop there, stop there.
Sure.
Just showing you the intimal hyperplasia. Look
Yeah.
at that. So you see the stent, there is,
Find out from
I would
PK
say
what is the other
whatever
peripheral.
you want to say, under expanded,
Under expanded,
compressed
yeah.
by the tower balloon when we did the tower. And then on top of that, intimal hyperplasia, right?
Yeah.
So
And,
thick intimal hyperplasia, you think there's some lipid inside
Yeah.
and
because
no
attenuation.
calcium behind. You
Yeah.
don't see that.
No.
So it is all some under expansion of the stent, compression of the stent with intimal hyperplasia.
Yeah.
So then comes, how are we going to treat? So there's two. One, there's no calcium outside the stent. There's no calcium inside the stent.
Now, if
So
it is
I
a
think-
calcium inside the stent means what? You have the stent
No,
already.
okay.
No,
Go back. Yeah,
theoretical. If there is a stent inside the if there is a calcium inside the stent, does it mean it's a neoatherosclerosis?
Yeah. That's also the
That's
neoatherosclerosis.
neoatherosclerosis. This
Yeah.
is also neoatherosclerosis because we see lipid.
Yeah. Lipid or calcium, both
Both
neoatherosclerosis.
neoatherosclerosis. So this is without calcium. So when there is no calcium inside, no calcium outside, if there's calcium inside, we could do either rotational atherectomy or laser. Now, just intimal hyperplasia without calcium, we opted for laser. Could we have done could we have done cutting balloon? We could have done just a cutting balloon. Could we have done high pressure balloon? We could have. Probably we'll see it will slip. Could we have done the rotational atherectomy? We could have done it. That also would have ablated. So any of this is possible. If there was calcium inside the stent, outside the stent, definitely rotational atherectomy. Outside, I think IVL would have been a better choice, since we know that penetration would have been deeper.
Right. And under expanded stent, we learned quite a bit today. We actually have published part of that also, and ISR when we wrote down the laser mechanism. So author really wanted to understand what the laser works. Said laser work for ISR, yes, but then there are papers about how the laser works in under expanded stent. So basically is that the vapors, the small bubbles, they explode in the particularly when you make a contrast, and that really expand goes through the behind the energy, laser energy, ultraviolet goes behind the stent struts and liquefy that atheroma or calcium, which is preventing the stent expansion. So there are papers about under expanded stent using laser, not only ISR but under expanded stent with laser. We actually have published our series of using a rotational atherectomy for those cases, and there always a question comes that does it ablate or it heats it? We are saying it does not ablate the metal because always covered by some intimal hyperplasia. It basically just heats it up, and that it liquefies the calcium behind the stent strut. That is one of the mechanisms of rotational atherectomy working for the calcific under expanded stent. Yeah,
in our calcific app, if you go and check the basics, we have described how laser atherectomy works with the nice slides, exactly the mechanism. And let's go back to the second picture after we did the laser. So what we see here, disruption. We also see this kind of disruption when we do rotational atherectomy also.
Absolutely, exactly. And that is supposed to be fundamentally the mechanism. Sameen, in the meantime, I have verified the coronary lasers are 0.9 and 1.4, and the peripheral are 1.7 and 2.0.
Okay.
And this kind of what you see here, we could also see when we do cutting balloon, which we have seen. So disruption.
Yeah.
So once we have disrupted the intimal hyperplasia, why this is important, that you have thick intimal hyperplasia, and sometimes expansion of the stent could be harder. That is why you need to disrupt it. Then you go with high pressure balloon like we did here. We knew the stent expanded, and then you restent it, knowing that there was some lipid, if there is a new intimal hyperplasia, or making sure that you are scaffolding the aorto-ostial lesion again with another layer of stent.
Okay, so then the final?
That's the final.
No.
Now, I mean, that's, you saw the nice interruption, and now this is the final. Exactly where you see two layers. Stop there. Stop where you can see two layers there.
Just also like 1 and 2.
You can see the two layer of stent. Right there. And nicely expanded.
And some protrusion of the plaque.
That you see some protrusion.
Some lipid plaque or some organized thrombus was there. That's why a lot of protrusion.
I think we have explained it clearly now.
Yeah. So I hope our viewers, if anybody has questions, they can ask, because there are already few questions flew before we got into this particular case. Yeah.
Several questions are talking about could we have achieved similar imaging benefits with IVS? With IVS?
IVS, yeah.
Mhm.
Yep.
I think you know, the understanding with the depth, yes, but not this kind of crisp picture that you would have seen.
Absolutely.
Right?
Yeah.
So we don't have understood
I
the
think
mechanism
this
better.
this level of resolution and imaging.
Yeah.
But more important is because we did not have calcium. If calcium would have been there, IVS would not have been that that precise.
Actually, this case is not much calcium, but if there's calcium, like differentiating the calcium, the stent is very hard.
Yeah.
So that's it. For this case, actually, I was also showed and expanded the mechanism. But if the calcified lesion OCT is of course better.
Yeah.
Now, since it was ostial, we were not sure. We actually had IVS open also in this case. So we did the OCT with some damped pressure, which you have to be very cautious. I had Will stand next to the patient because there's a risk of, you know, patient getting into ventricular fibrillation. So we have to be very cautious and not to do OCT with the damped pressure, but you know, it was when to do it right. You had to have the guide right at the ostium, not too deep, cannot have it outside, but when we had it outside, you know, we could not have a good picture. So that's why you had to have it right at the ostium, a little bit of damping, and then do the OCT.
Anu, any issues with using OCT in the presence of side hole catheters?
Yeah, since a lot of the dye is lost from the side hole, you don't have a crisp picture. That's why we had to do this. Otherwise, if this case was being done with IVS, we would have used a side hole rather than having a damped pressure all the time. Yeah.
Excellent.
And as you know, that lot of data coming now, particularly for the right coronary, that can you avoid giving the dye and do the saline OCT? Now they have tried gadolinium. They are working on another molecule which was just published in JACC. But key is for the right side, can you do it with the saline OCT? And seems to be okay picture. So maybe next time we'll do some practice of the OCT with the saline and see how the crisp comes. On the left side, people have done, they brought the guide liner and injected with saline through the guide liner. So the very small area of the blood-free vessel, so that you have a good picture even with the saline. So that's what we need to see. We'll do some our practice runs, and maybe we'll update our audience. I know Anu shaking head actually and Kiski that what are the data, but I'm just saying the literature.
Right, I think it's not clear. Pictures are not as clear as we think, and arrhythmia is still higher.
Anu, right? What about diluted contrast?
No, you will not see it. No, you have to complete disappearance of blood. That's the reason you get that kind of a beautiful image. Yeah,
absolutely. Okay.
Unless some new OCT, the energy comes down, that can penetrate the blood cells and so and can have a good picture. But right now there is all just radio frequency domain OCT. RF OCT. Okay, with that note, it's an excellent case. Now let's go to our usual discussions. If we can go back to the slides, please. So this case, as we talked about. I
just want also to know our calcified has a description of most of this, what we have discussed already, the app, and then I think we are having an second version of calcified coming out soon, which will include IVL.
And this particular case was appropriate, was a double drug. And you saw the 90+% lesion, although we did not do FFR, but even without that, this is without a stress test and so appropriate on our the vessels now. Also, as you know, the recent ACC, our guidelines in terms of revascularization have given emphasis on the particularly frailty, that presentation of frailty, and this is actually the Canadian Journal of Geriatrics, and this is called Clinical Frailty Scale, CFS. So basically, besides what we come with the syntax score, what we come with STS, it's also the frailty telling the patient that if patient could be otherwise acceptable in terms of the syntax as well as the STS, but frail, there is totally different treatment for those patients. So we'll be, in those elderly patients, we'll be presenting the frailty scale. In this particular case, it was grade 2, that people have no active disease symptoms, but are less fit than category 1. Often they exercise or are very active occasionally. So this patient is called frailty level 2. So today we are going to just talk very quickly. In our next 10 minutes, we have the bifurcation lesion intervention outcomes by 3 separate papers: impact of the lesion complexity, network meta-analysis of the technique, and physiological guided approach. And then focus review of the month is coronary in-stent restenosis, incidence, pathologic mechanism, patterns, and management strategy of coronary ISR. Actually, paper by us in Jack and our fellow Gennaro, as well as there is also simultaneous paper in Eurointervention. So let's talk about the complexity of the bifurcation. How do you define complexity? Actually, this goes back early, almost 10 years ago. They made this definition trial, definition study, basically to look at the impact. So what they did is they took the patients, one on the left side, initially they did the bifurcation, the training group, and then use that in the study group. So basically what they came up with, based on the side branch, left main versus non-left main side branch of 70% and the diameter stenosis of 90% in the non-left main and lesion length more than 10. Based on that, came with the 2 minor and major criteria, and these were the independent predictors, odd ratio as you can see here. Distal left main bifurcation with a side branch lesion length, then moderate calcification, multiple lesions, bifurcation angle less than 45 or 70, main vessel, reference vessel diameter less than 2.5, thrombus containing lesion, and main vessel lesion length more than 25. So they say complex will be 1 major or any 2 minor, or 2 major or any 2 minor will be the complex. So this basically the whole definition was made, and based on that they said that should we take care, though turns out to be once you have the complex lesion, your 2 stent is better, but if you have a simple lesion, your 2 stent actually had a higher trouble in hospital stent thrombosis and revascularization. So then they went further with a multi-center randomized comparison of 2 stent versus provisional stenting technique, means 2 versus 1. Simple that way to remember. And they actually, in these complex, based on the criteria, divided that patient has to have a complex lesion. Provisional stent group means 1 stent, or 2 stent group, followed these patients for 1 year and 3 years. So what did we learn in 1 year? That using 2 stent approach in a complex lesion, now we are taking only complex, not the simple. Complex has a lower TLR, lower target vessel MI, and TLF along the individual endpoints here, and non-statistically lower stent thrombosis. So 2 stent approach in a complex lesion did better at 1 year. So same people then came up now last month with a 3-year outcome with the 2 stent approach, and you basically same group then followed up to 3 years, and they basically saw the persistence of the benefit of 10.4 target lesion failure versus 16% with the provisional stenting. So 2 versus 1, individual endpoints are shown there. All favored 2 stent approach even at 3 years in these complex lesions. Now you say, well, why was the benefit of 3 years? Was it at 1 year or it continued to accrue? Very nice individual endpoints are shown here, but more important is the landmark analysis. Look at the 1 year. 1 year 6.1 versus 11.4. What happened after 1 year? No difference. So basically what it showed, that in complex lesion event continues to occur even after 1 year, up to 5% at 3 years. But there was no difference in 1 or 2 stent. So key is, what are the benefit of the 2 stent approach? We had it in 1 year, not after 1 year. But just to say that the complex lesion story doesn't end at 1 year. The event rate another 5% at 3 years, which was shown. And then of course, if you have only provisional group, you have 1 or 2 stent, that clearly was showed that although that if you have provisional, anytime you put 2 stents in the provisional, you always have a trouble. And that actually we learned from the DK Crush 5 also. Remember, 46% in the provisional stent, they got 2 stent. And the bad outcome compared to DK Crush was because they put too many 2 stent in the provisional group. So all this study also showed that in the provisional, when you use 2 stents, which used about 24% of cases, has a bad outcome compared to one stent. And of course, if you have procedural complication, same thing happens there. So this is basically the message was that both complex lesion have event after 1 year. Secondly, the benefit of complex intervention with the 2 stent is in first year, not after 1 year. So this actually goes back to the DK crush. Remember, DK crush had the simple lesion as well as complex. The benefit was more of the DK crush in the complex versus simple, although you can see the hazard ratio was there, particularly more so for the complex lesion. So complex lesion with the DK crush, better, knowing that 46% of these cases got the 2 stent and so. So this is, and this actually goes back to the little point which we had of the EBC main, that clearly you need to decide stepwise or put a directly 2 stent approach. Now, then of the various stenting technique, there is a meta-analysis just published about which one is the better outcome of various stenting strategy of the 21 eligible trials. And these are the various trials name, their follow-up, their size, they're taking a crush, cool out, and DK crush or tap. So 4 of them. So crush, cool out, DK crush, and tap. And this is actually the key slide. What shows that all the trials showed that DK crush is superior compared to the provisional or non-DK crush technique, as you can see here. Others are still not harmful, but DK crush shows superior. Individual endpoints are shown here. Myocardial infarction, TLR, stent thrombosis, particularly TLR, DK crush was superior compared to the contemporary. So now then the question always comes 1 versus 2 stent based on the side branch length. Once your length is more than 10 millimeter, and this is a basically same definition, 2 criteria. Definition criteria that longer the side branch length, better is that you go with a 2 stent compared to 1 stent approach. So this basically review meta-analysis showed that, and that actually is now 2A. Our ACC guidelines, the DK crush approach is better compared to other, but not class 1, but DK2. Then there is another paper came, the physiology. We always talk about side branch, you stand, not stand, decide based on the FFR, and so this is a combined statement. They actually went a little further. They said not is the side branch, it's ischemia. It has to be the territory of ischemia. So their case on the left side, circumflex, large area of ischemic territory. There is a diagonal, much tighter lesion. Both of them have positive FFR, means low FFR, but a small ischemic territory. So question is what you should do, and you should define. And we all learned that many times you have a 80+%. Lesion could be very significant, but your FFR is not significant, which we have learned many cases and so. So then benefit of course, anytime you want to do FFR, there is always a plus and minus. Always is that if a tortuous calcific lesion, you can cause dissection. These are the randomized, only one randomized trial. DK crush 6 of the 320 patients, others are shown there. So that FFR or IFR guided intervention, the main finding on the right side, none of the trials showed that using the FFR or IFR is beneficial, including the randomized trial of DK crush. Therefore, we stopped doing the routine FFR IFR measurement to decide whether we should take care of the side branch or not. And there, of course, now we have more new novel techniques with the various imaging, with the CT and angiographic. The CT angio derived FFR. So they actually put this as a algorithm. I do not completely agree with this algorithm, but I have to just go through it, what is in the literature. So clearly that if you have a significant side branch, go with the 2 stent. We have provisional side branch stenting, and actually you can see here that if angiographic stenosis, they actually define, you decide whether it's a 60%, 80%, that variable. So if you have a tight lesion after your stent with a 1 stent provisional stent technique, and if you try to with a significant lesion, then you can decide based on the FFR or IFR. But I would say that, of course, if it is a significant, whether you put a stent or not is always questionable. Randomized trial or other data have not shown, but medical therapy is good enough for these cases. So lastly, let's go to our focus review of the month. That is the coronary in-stent restenosis. Paper came out from our cath lab, all our the members here. In this, as you can see, with we got Antonio Colombo also to put that introduction of the subsequent iteration of the DES technology have substantially improved the efficacy and safety of PCI. However, the incidence of ISR and need for repeat revascularization occur in 1 to 2% per year. given that millions of drug-eluting stents are implanted each year around the globe, ISR can be considered as a pathological entity of public health significance. The mechanisms of ISRs are multifactorial. Since the first description of the angiographic pattern of ISR, the advent of intracoronary imaging had further elucidated the mechanism of patterns of ISR. The armamentarium and treatment strategy of ISR have also evolved over time. Currently, an individualized approach using intracoronary imaging to characterize the underlying substrate of ISR is recommended. In this paper, we comprehensively review all this. So key is, this is actually what we did today, was a classical example of what I would have done it without imaging and what we changed after the imaging. So clearly, even Samir, when you asked that do the high pressure, actually Anu wanted to do just high pressure or maybe just cutting balloon so it doesn't slip. Probably could have been fine. And that only we got assurance by the imaging that it was not a calcified, it is not a distorted stent and so. So as you see, we have made a lot of work required. This took 9 months to write that paper, and I really have to give the credit to our international fellow now, Gennaro Justino, who actually worked on it as a second and third year fellow before he became interventional. So key is, as we mentioned, few percent restenosis continues to occur even with the latest generation of DES. So what we did is, so key point, the story doesn't end at 1 year. So just to say, we used to tell the patient after 1 year you are home free. Not true. Few percent will continue even after 1 year, even with the newer drug-eluting stent. Just want to say that. And of course, the lot of the improvement in the stent technology with the thinner struts, and more important, this is a very key slide. Put back some of the question, Samir, you ask, maybe our audience ask about the factors of the ISR. Anatomic factors with the calcification, bifurcation, ostial, long lesions, clinical factor, diabetes, kidney disease, older age, previous cabbage, female sex, obesity, and then stent related, where stent is underexpanded or fracture, miss, or thicker stent strut. One actually, I got 2 emails after the paper came out, where they asked us, we made a big mistake. We did not include the smoking. And look at that one. We looked into it. Smoking, actually, we have papers to say smoking has lower restenosis in the particular BMS era. So I know smoking is bad for the natural CAD, is bad for the grafts, but there are no data of smoking for the ISR. I just want to emphasize this because I already answered to our reviewers, the people who asked the question of the impact of smoking and not as a risk factor in this. And of course, we know the histopathology, a little different, whether it's a drug-eluting stent or bare metal stent or first generation. And the key is the various characteristics of the ISR we are really put down in terms of angiographic, OCT, histopathology, and more important is the original Mehran's classification. Now, based on the imaging, you have a different physiological subset, and that is what, and phenotype, which I would say, and that is the characterization. There is a separate on the OCT based on the neoatherosclerosis, type 1 to 4, which we presented a few years ago. But key is that adding the imaging really has changed our management and understanding of the ISR under expansion, which is the case which we have shown. Now, then what are the randomized control trial for management of the ISR? So we actually have many of them originally with the brachytherapy, and then you have cutting balloon, then you have bare metal stent era, then you have the drug-eluting stent, all shown there, RIPS 5, RIPS 6, and then drug-coated balloon trial. So all of them have been, we have put into this manuscript. So just to sum up the few things, people always ask, which case would you use a drug-eluting balloon or repeat DES? Very simple. Aggressive ISR, repeat DES is better. And drug-coated balloon is small vessel, bare metal, and multi-layer ISR will be the, and there is a branch issue. And these are the individual comparison of the drug-coated balloon and various everluminous eluting stent against other strategies. So key is also people ask, what about your depth duration? This actually went multiple times with the back and forth with our reviewers, and they finally we settled for this, that clearly that if you are using a drug-coated balloon or non-re-DS strategy, 3 months of depth is good enough. But if you put a repeat DES, you should give it for 1 year, if not even longer. And you do IVBT, then you definitely have to give it for more than 1 year. And that has been is that we give it for 3 years and so. So lastly, this is the central figure. And I want to take just a few seconds on this to identify in-stent restenosis, identify the mechanism of the IVUS or OCT, DES under expansion. You go to the left side, high pressure, rota, repeat DES, and nominal vessel size, or IVL in under-expanded stent if there is a calcific lesion. So this exactly answers the question which we have discussed today. Now, you have the neointimal hyperplasia or neuroatherosclerosis. We said that there is a two separate dichotomy. You have one layer of ISR or two layers of ISR. So one layer of ISR, focal edge, you probably go with a high pressure balloon, and there you have a choice. You can use DES or drug coated balloon. But if you have diffuse or CTO, you always want to go with a repeat DES. Now, once you have a two-layer ISR, so question comes, two-layer at the focal or edge, you can just do the high pressure balloon dilatation and IVBT. But if it's a diffuse, so there you want to do a drug coated balloon. We don't have much data on the IVBT in those cases. Recurrent ISR, consider cabbage, particularly left main, large proximal, multi-vessel disease, and patient is a good surgical candidate. The surgery is still an option for many of these patients. So this is, we have put it very nicely. So just come back to now similar paper, little different, but came also in the Euro intervention the same way, management of ISR. They actually have stent favors, new intra-stent, extra-stent, little different terminology. Very nice, this diagram of various trials of devices, right from the balloon angioplasty to the drug-coated balloon and re-DES. I like this slide. That is the major principle of managing ISR. One, you define, identify the culprit, assess the lesion length and severity, use intravascular imaging to define the mechanism of ISR. Then prepare by routine pre-dilatation of all lesion, use high pressure, cutting or scoring balloon, address all mechanical factor, and then treat DES ISR or the drug-coated balloon that always remains. If you have BMS, then the drug-coated balloon is a very good option based on the RIPS trial. And then, of course, you do IVUS imaging in the end to have a ultimate outcome. So with that note, we come back to our take-home message. MACE after 2 stent versus 1 stent in complex lesion, answer is yes, yes, yes. But we also learned overall MACE and clinical outcome after 1 year is nothing to do with the 2 stent. It just those they have a bad outcome because continues to have event rate. So 2 stent, good for 1 year, not after 1 year any additional benefit. Second, 2 stent strategy of DK crush versus others for MACE, thumbs up. Then utility of physiology test of as side branch in bifurcation PCI, questionable. They actually, authors were not very clear in that central figure in this JACC intervention paper with this Japanese, Korean, and European club. But I would just keep it that our practice has changed. We do not routinely check the side branch based on the physiological testing. Then overall incidence of ISR has declined over newer generation PES. Remains a challenge. And of course, the first episode, imaging is very important. First episode DES ISR is best treated by DES, while multi-layer DES ISR remains a significant challenge with drug-coated balloon and IVBT having limited success. Cabbage is a viable alternative in selected patients. So 3 questions. Following are the major or minor criteria of complex lesions as defined by the definition trial, except lesion side branch length of more than 10, side branch diameter stenosis more than 90 for non-left main, side branch diameter stenosis more than 90 in left main lesion, severe calcification, multivessel lesion length, and answer there was C. Is not correct because 70% for the left main. Side branch more than 70% is a complex lesion, major criteria. Second, following statement is false regarding the long-term outcome of simple versus complex lesion in the definition trial. One is complex lesions continue to have higher MACE event after 1 year. Complex lesions have better outcome after 2 stent versus 1 stent at 3 years. Complex lesion can easily be identified by the set criteria. Complex lesions have better outcomes at 1 year after 2 stent versus 1 stent. And complex lesion continues to have better outcomes after 1 year up to 3 years. And answer there is wrong. Answer is E. Because only benefit is up to 1 year, not benefit from 1 to 3 years. The third third question, is following statement is false regarding the mechanism, risk factor, management of ISR. Diabetes and CKD are important risk factor. Stent under expansion and low is MLA risk factor. Calcified bifurcation lesions are risk factors. Chronic smoking has been a known risk factor. And neointimal hyperplasia is the predominant pathology. We've already spoken about that smoking is not a risk factor so far as we know in the literature for the ISR. And with that note, we conclude our presentation, case as well as the didactic discussion for today.
Samin, such a wonderful, comprehensive review. I think I go back to many times. Today's focused review is exactly relevant to the case which we showed. Everything changed with imaging, our strategy, our plans. I have a follow-up question with you regarding a one stent strategy for the provisional group. What if you have significant plaque shift, which changes everything? Would you then proceed with the second stent or stay with your initial strategy?
No, so that is why in the provisional stent group, anywhere from 13 to 46% second stent is needed. And second stent is precisely needed for this purpose. So what you do is, if your side branch get a significant plaque shift, first you do a kissing balloon. It doesn't get better, then you put a second stent. And that could be anywhere from 12 to 46%. Even in the EBC main, the 22% requires second stent. So clearly, that side branch plaque shift is a common phenomena and can be taken care majority of the time with a balloon dilatation, kissing balloon. But if you still have a compromised flow and dissection, then you require putting a second stent. So that is part of the still provisional stent approach, but that provisional stent approach requiring second stent. The point is very important. Every trial has shown, once you put a two stent or the provisional stent approach has a bad outcome compared to your single stent approach. So key is that anytime when you do a bailout, second stent is not good. So I always say the strategy of or controversy of two stent versus one stent is not that whether you can put a two stent or not. No, you need to identify the lesion which are going to need two stent and go with the two stent approach proactively.
Excellent. Anu, final words from you?
We just want to show the slides of the laser, how it works, mechanism, and I think more and more we have shown over the years that mini crush is the way to go. I guess we have to analyze our own database and see the outcomes after 1 year on this case. So this is our calcificate, that's currently available. If you see there, first page, it will tell you, you choose what kind of lesion you're treating. So here we could go to the first one, which is non-bifurcation lesion. And then we have included imaging even at that time, 6 years ago, that when we made this. And after we do the imaging, depending on what the the cause of intimal hyperplasia or what the cause of in-stent restenosis, or then you can go to calcification. I mean, whether it's calcified or in-stent restenosis. Next slide.
Yep.
Yeah, non-bifurcation imaging. So if you have decided, this is, I think, what we were trying to describe how laser works. The first slide itself, which is the basic of how the laser works, which is photothermal, photochemical, and photomechanical. That's exactly what we showed here today. How it will work on the intimal hyperplasia, how it will work on calcific lesion, or any kind of fibrotic lesion. I think the other cases where we really, this becomes very helpful is you crossed a chronic total occlusion with your CTO wire and you're not able to advance anything else. You can create a path using the laser, provided you know that you were in the true lumen, not subintimal. If you're subintimal, avoid using a laser. But this becomes very handy in that situation also.
Anu, I'm glad you showed this. In closing, I also want to recognize one of your silent, unsung heroes. We see him so often. In this particular case, it was his work which made the difference. Kiski. Amazing guy, a wonderful, wonderful guidance he provides us through his rock solid interpretation of imaging. We conclude here and we'll see you on September 20th for our next webcast.
Okay, good.